Hello, everybody. My name is Paolo Veneri, and I am Deputy Head of Division at the OECD Center for Entrepreneurship, SMEs, Regions and Cities, in particular the Division on Economic Analysis, Data and Statistics. Today, I'm presenting a paper of submission number 11A, titled Understanding the Geography of the Health and Economic Impact of the COVID-19 Pandemic. So my presentation in this conference is mainly focused on subnational data for policy. Most of the indicators, statistical indicators that we are presenting, and also of the quantitative analysis that we have carried out, is based on a publication that is called Regions and Cities at a Glance. It's a biannual publication published by our center at OECD, which really strongly focuses on regions, cities, and more generally on the subnational dimensions of demographic, economic, environmental aspects of OECD countries and beyond. In this specific case, today, and I'm getting to the outline of this presentation, I will focus on the impact of the pandemic. In particular, most of the presentation will cover the health impact of the pandemic through an analysis of comparable indicators in terms of mortality, all-cause mortality, where we will look at the patterns of mortality across and within OECD countries, and then we link this impact with the extent to which different regions in OECD countries were prepared to face the health crisis. I will then finalize the presentation by with a few slides on how from the health impact of the pandemic, regions have been experiencing, let's say, an economic impact, and in particular, I will present some considerations about the role of remote working within countries. So, first of all, let me show you let's say, the map that represents the key indicators that we are looking at during this presentation, which is what we call the excess mortality. So it's the difference between the total deaths occurred in specific regions within a specific month of 2020 compared to the same month or other window of time when compared with that period taken as an average of the last 2, 3, or 4 years. This difference gives us what we call excess mortality, and it's a good proxy, especially for making international comparison of the health impact of the pandemic. Even if it doesn't count specifically the cases, so the deaths due to the pandemic, it's an indicator that when we see, let's say, a peak, an increase, a significant increase in excess mortality, then we can have a proxy that is robust enough to make international comparisons and, let's say, avoid the measurement bias due to difference in testing and differences in monitoring the causes of deaths in the different countries. So what's the rationale of doing this analysis? Again, the objective here is, first of all, to describe the pattern of excess mortality through data and indicators on excess mortalities collected through the different statistical offices or administrative registers. The rationale is that, of course, with the pandemic, we had an increase of deaths during 2020 of about 14% compared to previous years. This means about 1.5 million more deaths compared to the previous 2-3 years that occurred in OECD countries. Another aspect for which we are doing this analysis is that this health impact of the pandemic has had a very uneven spatial, let's say, the impact was very uneven from a spatial point of view. In particular, within country gaps across, let's say, if we compare regions within the same country, on average in OECD countries, there is a 17 percentage point of difference in excess mortality that was observed during the year 2020. And in addition, there is a fast-growing literature trying to document and to explain, let's say, the health impact of the COVID-19, but there is very little done from that cover both several countries and at the same time with a geographically granular perspective to look at the patterns within country. So what we know about this, about the map that I just showed, if we look at the figures, we see that only 5% of the regions had didn't see any increase in mortality compared to the previous 3 years. For 1/5 of the regions, there was an increase higher than 20%. And for 8% of regions, subnational regions in OECD countries, there was an increase higher than 30% in terms of total deaths. Many hardest hit regions with, for example, more than 30% more deaths compared to the previous years are regions that host very large cities, such as New York region, Lombardy regions that host Milan, Madrid, or Mexico City, for example. There was a higher health impact in large metropolitan regions than in more low density and remote regions. Now, that being said, we look at what were the conditions of regions before the pandemic, before the shock and at the start of the pandemic. Not all places were equally prepared to face the health crisis. We wanted to explain the variation of this excess mortality by looking at specific features of regions from different points of view before the start of the pandemic. So when we say preparedness, we can consider different aspects. First of all, the availability of hospital beds, the health system capacity, one first very simple indicator of health system capacity. We see, for example, from a descriptive point of view that, let's say, regional disparities in terms of availability of hospital beds per 1,000 inhabitants are much higher today than it was 20 years ago. In particular, there was, during the last 20 years, a concentration of, there was a reduction in all regions in terms of availability of hospital beds, but more interestingly, there was a concentration of this type of infrastructure, of health infrastructure, in large cities or metropolitan regions, while there was a reduction, a stronger reduction in that availability in more remote regions, as it is shown in this chart. Basically, classify all the small regions, subnational regions in OECD countries according to their settlement pattern. We distinguish, let's say, 5 types of regions. We have large metropolitan regions with at least a city of 250,000 inhabitants, regions near metropolitan area. Then we have regions near small, medium-sized city, and then remote regions. We see that if we compare the availability of hospital beds in 2018 with that in 2000, we see that that availability has decreased in all types of regions except in the large metropolitan regions. And this has increased the regional disparities in this respect. But the availability of hospital beds is not the whole story. Regional disparities are very high also in terms of other types of infrastructure or types of health facilities. For example, doctors per capita are also very different within the same country. This chart shows, for example, across almost all OECD countries, the regions with the minimum and the maximum value of doctors per 1,000 inhabitants. And there are important differences within country. On average, let's say there are 4.4 doctors per 1,000 inhabitants, but within country there is 2.3 doctors per 1,000 inhabitants of difference between different regions. We can think that this availability of health facilities might have played a role in terms of the impact of the pandemic, especially at the beginning when it was very hard shock at the beginning. But actually, we also consider other aspects connected to health. For example, the morbidity, so the preconditions of health condition of people within regions. In this case, we have collected also information on the percentage of people suffering from specific diseases like diabetes, like obesity. This chart shows, for example, the share of people affected by obesity among the adult population, and we see that in some countries, I mean, there are very high numbers, like for example, in Mexico, Chile, and the United States, close to 40% or more of the population is obese, and we know from the literature that people with specific pre-existing health problems are more vulnerable if infected with COVID-19. Therefore, this is another place-based dimension that we consider in our analysis. There are also some, let's say, context aspects, especially in terms of environmental outcomes, like, for example, air pollution. There are specific studies documenting the importance of good air quality for making people less vulnerable to diseases like COVID-19. And we have considered these specific outcomes, so the levels of PM2.5 within, let's say, all regions in OECD countries and also cities at different scales. We have estimated these trends in air pollution from 2010 to 2019. We have seen, while we have seen a reduction in most places in terms of air pollution, we still have, let's say, practically all OECD countries having at least one city with air pollution levels above those recommended by the World Health Organization. So this is another aspect that we have considered. So coming back to the purpose of this first part of the analysis was that how can we explain the patterns of COVID-19 health impact measured in terms of excess mortality? We have looked at different aspects, as I showed in the previous slide. We have shown characteristics in terms of health system and preconditions in terms of morbidity, environmental aspects, but then we have also considered other specific aspects related to demographics and socioeconomic, for example, the share of elderly population or the income in a region, etc., etc. We have also information about institutions and policies. For example, we have proxies of quality of government measured in terms of trust in the national and local governments, the extent to which the mobility of people were reduced due to curfew and confinement measures. And then we have, of course, geographical settlement information, such as population density, type of settlement patterns in the regions. All these statistical indicators, almost all of them have been included in our publication, OECD Regions and Cities at a Glance, or are published in our OECD regional database, with some of the indicators, some of the variables that have been, let's say, produced specifically for this analysis. So in this table, we have run before running our model, that was a linear regression model. We have, let's say, performed a simple correlation analysis to see whether there was, let's say, potential issues of multicollinearity across the different variables that we have considered. You can see, for example, that in terms of health system capacity, we have hospital beds and physicians per 1,000 people. In this case, we have given that they are highly correlated, we have built one single index on that, and we have excluded the indicators in red because they were linearly too much correlated with other variables, and were already kind of what we wanted to control for were already controlled with other indicators. And for the rest, we kept all this information from income, population, density, air pollution, demographics aspects, health system capacity, the characteristics of the labor force in terms of education, and so on. So we go straight to the results. The results were obtained through first a baseline model that used ordinary least square model, and then that was complemented by spatial models to take into account the let's say the spatial autocorrelation of residuals, given that our units of observations are spatial units, are regions. Therefore, our model account for spatial correlation, account for country fixed effect, and account for, let's say, potential heteroscedasticity. Therefore, we use robust standard errors. Our main findings include the fact that using our sample of 342 regions in 32 countries, that belonging to the OECD or to the European Union, the main results are as follows. Across all the phases, all the months of the 2020s, all the phases of the pandemic that we could observe in this work, two main, let's say, factors that were correlated with higher excess mortality was having a weaker health system capacity and having higher population density. As expected, of course, population density has been always connected in, I think, in all type of pandemics with higher health impact, and the health system capacity is also expected to play a role. Then some specific aspects, such as the lower institutional quality as proxied by trust in government, or the share of elderly population, which we know elderly people were particularly vulnerable to the COVID-19. These specific regional features were playing a role, especially during the first moments of the pandemic, first months of the pandemic. On the other hand, there was also a role that emerged in terms, let's say, in terms of correlation between air quality, in particular, a positive correlation between air pollution and excess mortality, and this correlation was particularly strong in later and longer later stages of the pandemic. Let's say July, August, starting from July, August 2020. This analysis was based, as I said, on a spatial model that was organized in a cross-section of 342 regions. A cross-section in which the excess mortality, different windows of time within 2020, were associated to pre-existing regional features, so before the pandemic. It was a cross-sectional model. On the other hand, we also ran a panel model, completely different approach, just to look at another aspect, that was the mobility of people. In particular, the question was, is excess mortality associated with mobility of people? By mobility, we mean the extent to which people move, for example, home to work mobility, and so on. We know that many countries introduce containment measures by reducing dramatically the mobility, with a lot of, let's say, shifts from presence working to remote working. And therefore, we tried to capture this reduction in mobility and relate it to the excess mortality outcome. What we set is a panel model in which we regress excess mortality changes month to month in region R and month M to relative mobility changes that we could measure through the Google mobility reports that were published by Google during 2020 already. Also, in this case, we have run the model both in terms of with and without correcting for, let's say, spatial autocorrection of the residuals. When I spoke about the mobility of people and the change in mobility through the Google mobility reports, this is a chart that explains a little bit what we are capturing. For example, in the case of UK and Spain, we can see that the chart provides the change in the mobility of workplaces. So we could imagine workplace, home to work mobility, that in March 2020, there was a huge and dramatic and sudden reduction of such mobility. But if we distinguish types of regions within country, for example, if we distinguish large metropolitan regions, for example, London and all the regions with a metropolis of at least 1.5 million inhabitants, with the rest of the regions, in most countries, we see that the reduction of mobility in the large metropolitan regions was higher than in other regions. We use that type of variation, so the difference, the extent to which in different regions there was a different change in mobility, to see whether this played a role. Why in some regions there should be, within the same country, a higher reduction? In some countries there could be an heterogeneous, let's say, containment measures by regions depending on where the virus was spreading faster or slower. But there could be also, let's say, structural differences in terms of number of occupations that are amenable to remote working. We know that in metropolitan regions, a much higher share of jobs are jobs that are amenable to remote working. Therefore, it's possible to reduce more the mobility than it can be done in other regions in which there are less jobs, less occupations in which that can be performed remotely. That's the so what are the results of this panel model? The main message is that decreases in home to work mobility are associated with lower excess mortality. With a delay, we observe a delay. There is a delay effect of about 2 months. If you want to give a magnitude as an idea of magnitude, even if it should be interpreted out of caution, if we reduce the mobility today by 25%, then in 2 months we would have a decrease in excess mortality by 1 to 2.5 percentage points. This is, of course, only association and not causation. Results are robust to control it for country, month, fixed effect, and spatially lagged errors. So just to give a summary of this analysis, in which we wanted to explain the geography of excess mortality, we know that place-based characteristics overall explain, at least in part, the highly unequal impact of COVID-19 within countries. Localized health system capacity, but also population density are the most robust predictors of low excess mortality. Population density in negative terms, of course, but there are other aspects that are important, from air pollution to trust in government or reducing mobility. Inequalities in vulnerability across places emphasize the need for a territorial approach for managing the pandemic. For example, focusing, or prioritizing specific measures to contain the virus or to fight the virus through the vaccination, where the spread of the virus is most is faster. I would like to finalize the presentation with a few slides on the fact that from the health impact, there was, as I mentioned, there's been also a deep economic downturn that can potentially exacerbate the long-standing, already existing regional disparities, regional economic disparities. In particular, if we look at, for example, the last decade, what happened within OECD countries. Regional disparities did not increase dramatically. I mean, they were overall stable, but in half of the countries, regional disparities have increased in the last decade, and in half of the OECD countries, regional disparities have decreased. So where we see that there was actually a significant increase in disparities if you look by type of region. So if we aggregate all regions in OECD countries by type, then we see that metropolitan regions and non-metropolitan regions that are close to metropolitan areas, so regions that are either that host or that are very close to metropolitan areas, have had a different pattern until before the pandemic, long-term pattern of increasing GDP compared to more remote regions. So this is a pattern that, in a sense, characterized the evolution of regional disparities, regional economic disparities during the last 10, but even longer periods. 10 years or longer period. Now, with the pandemic, there's been an important change, which has been the fact that there was a massive shift towards remote working. That could change, actually, or could either exacerbate or change or be neutral with respect to this trend of evolution of regional disparities. What we see is that we estimated the share of jobs in regions that are amenable to remote working in each country. And we also did it by aggregating just types of settlements: cities, rural areas, and sort of intermediate areas that we call towns and semi-dense areas. And what we see is that, first of all, let's say the share of jobs amenable to remote working can be very different within countries. Even on average, the difference that can reach 20 percentage points or more. On average, regions that have the highest share of people that can, if needed, perform their jobs remotely, these are much higher on average in large metropolitan areas or large metropolitan regions like London, especially the capitals, Stockholm in Sweden, Zurich in Switzerland, Ile-de-France with Paris in France, and so on. In most of the cases, it's the capital regions of the largest cities, the regions with the highest share of jobs amenable to remote working. And if we aggregate, or we tabulate this estimation just by type of settlement, just distinguishing cities, people living in cities from people living in rural areas, then we see that there are on average 13 percentage point higher share of jobs amenable to remote working in cities than in rural areas. So this to say that that if anything, I mean, this specific aspect of the pandemic, so the massive shift towards remote working, might have exacerbated the existing disparities. So we have observed the long-term trends in which large metropolitan regions, let's say, were increasing their GDP per capita levels compared to their more remote regions, and the fact that this elements of resilience that could have been provided by the remote working opportunities during the peak of the pandemic, this has allowed, I mean, many economic activities to remain in place significantly more in specific regions than in others. Of course, the potential of remote working is not the whole story. In order to perform remote working, it's also important to have specific skills, to technological adoptions, but also good digital infrastructure. In terms of digital infrastructures, we also see that there are differences between, let's say, cities and rural areas. This chart, for example, shows prior to the crisis, the percentage of households with access to fast internet, And we see that in many countries there is still a very important urban-rural gap in terms of speed of connection. Summing up, there are important aspects behind the resilience of places or specific regions to the pandemic. So importance of well-functioning digital infrastructure, skilled labor force, including digital skills, and advanced economy in a digital world. We saw the importance also of environmental quality for health and well-being, but it also includes aspects such as trust in government, and also it's important the capacity to provide public services, especially in sparsely populated areas. Public services, of course, in this case, linking to the previous part of the presentation, linked also to the health system capacity. And with this, I will stop and thank you all very much. Bye.